Hello friends, so we're going to talk about macrocytic anemia here. And macrocytic anemia would be an anemia, so fatigue, weakness, malaise, pallor, those are the nonspecific but typical symptoms of anemia in conjunction with a high MCV. So remember that MCV is mean corpuscular volume, and that's just the average size of the red blood cells, of the blood cells that are in the blood. So it's just an average size. If it's greater than 100, then it's considered high. And if you have an anemia with an MCV greater than 100, then that's considered a macrocytic anemia. Now, you can have a macrocytic type anemia. I'll just say that macrocytic anemias are caused by B12 and folate deficiency. You can have an anemia caused from B12 and folate deficiency with a normal MCV if it's happening in conjunction with iron deficiency, which remember is a cause of microcytic anemia. So you've got both big cells and small cells in the blood at the same time, then the average is going to be normal. It's going to be an MCV between 80 and 100, but you really indeed do have both pathological processes going on. So you can't just look at that MCV and determine right there if you have a macrocytic anemia or a microcytic anemia. You could have both at the same time. So what you're going to look at is the red distribution width, red blood cell distribution width. And what that tells you is the distribution from the smallest cell to the biggest cell. And if you have an elevated red blood cell distribution width and a normal MCV, that should make you think possibly we've got a microcytic and macrocytic anemia going on here. So just to let you know, you can have a false normal MCV and still have a macrocytic anemia. So as mentioned, both vitamin B12 and folate are, when they're in deficiency, are causes of macrocytic anemia, and they are required substrates for the maturation of blood cells. So without B12 and folate, blood cells will remain immature. Now, it's red blood cells that we're most concerned with, most focused on, because that will show its symptoms first. However, platelets and white blood cells also require B12 and folate to develop as well. Immature cells are larger, so that's why we've got the higher MCV, we've got bigger cells. That's just because immature cells are larger. Red blood cells get rid of their nucleus. They get rid of their nuclear material before they become mature red blood cells. So they get smaller as they mature. So if you don't have the B12 or you don't have the folate to mature your red blood cells, you're going to have larger cells, which is why you have the higher MCV. So with inadequate B12 or folate, you're going to have larger cells sent out into the bloodstream, and because they're non-functional, they can't carry hemoglobin. That's what's causing the anemia. And because you have larger cells, again, that's what's causing the macrocytic anemia. So this is just a diagram of blood cell maturation. You can see here the red blood cell line, the pronormoblast, basophilic normoblast. Don't memorize this. Just remember that you've got smaller as you get more mature. And with the another thing you can commonly see in macrocytic anemia with B12 or folate deficiency is the polysegmented neutrophil. We'll take a look at that in a little bit. Okay, so let's remember back to our biochemistry. What does vitamin B12 do? Well, it does a lot of things, but for the blood, we are concerned with the metabolism of methylmalonyl-CoA and of homocysteine. So methylmalonic acid goes into methylmalonyl-CoA, and vitamin B12 helps that become succinyl-CoA. Homocysteine and folic acid come together, and with vitamin B12 as a substrate, combines to become methionine. Now, none of those reactions are really that important. Yes, they're both needed for red blood cell maturation, but what I want you to remember here is the reactants. So if you have a deficiency of vitamin B12, so you cut this out of the picture, neither of these reactions can happen. So you're going to get backup products. You're going to have increased methylmalonic acid because you can't go to succinyl-CoA, and you're going to have increased homocysteine because you can't go to methionine. So in vitamin B12 deficiency, you have elevated MMA and elevated homocysteine biochemically. Now let's say you have a folate deficiency. Folate, folic acid, same thing. If you have a folate deficiency, you're not going to be able to convert your homocysteine to methionine. So you'll have an elevated elevated homocysteine. But your methylmalonic acid going to methylmalonyl-CoA into succinyl-CoA via vitamin B12, that pathway is going to just go on fine. It's not affected by folic acid. So you'll have a normal MMA. So if you ever get a question where it says the patient has an elevated MMA, that tells you that the patient has a vitamin B12 deficiency. Vitamin B12 deficiency and elevated MMA, those are the same thing. But if you have just elevated homocysteine, then you have a folate deficiency. If you have both elevated MMA and elevated homocysteine, that's a vitamin B12 deficiency. Hopefully this picture will help you visualize that. And both succinyl-CoA and methionine and what they produce are needed for red blood cell maturation. Okay, so an overview of macrocytic anemia here again. The characteristic pathologic finding in macrocytic anemia are the large, immature red blood cells known as reticulocytes in the peripheral circulation and hypersegmented neutrophils. Remember that reticulocytes shouldn't make up more than 2 to 2.5% of the circulation. So if you're getting very high reticulocyte count, large immature red blood cells in the peripheral circulation, then it means that likely you're not getting normal maturation. And so this is a reticulocyte here. This could just as easily be normal, although we have a poikilocyte here. And then this is a hypersegmented neutrophil. This is what you want to look out for when you're thinking macrocytic anemia. Now, you're not ever going to get any pictures like this on step 2 or step 3, but they may tell you you have large immature red blood cells, and they certainly will tell you you have hypersegmented neutrophils on your peripheral smear. That they can tell you in words, and that's sign of macrocytic anemia. Hypersegmented neutrophils means a neutrophil with more than 6 lobes. Here we count here, 1, 2, 3, 4, 5, 6, 7, 8. 8 lobes to this neutrophil. So this is a hypersegmented neutrophil. So this is an immature neutrophil. And so that's a sign of macrocytic anemia. We're not getting maturation of the blood cells because we don't have either B12 or folate. So the causes of macrocytic anemia, as you've probably gathered by now, are vitamin B12 deficiency or folate deficiency, or theoretically you could have both at the same time. But let's go over each of these. So vitamin B12 deficiency, classically we see these in alcoholics and the malnourished, and alcoholism and malnourished kind of tend to mesh together. So alcoholics, the malnourished, and vegans. Why vegans? Because vitamin B12 is found exclusively in animal products. It's meats, eggs, and milks. So people who don't eat, for philosophical reasons, who don't eat animal products are at risk for vitamin B12 deficiency. Now, in your liver, you store about 2 to 3 years worth of vitamin B12. And that's assuming you're healthy. So if you eat meat on a regular basis or semi-regular basis, you eat animal products, milk, or whatever, you've got 2 to 3 years worth of vitamin B12 in your liver. So if you go 2 or 3 weeks without eating meat, you're fine. You're not going to develop vitamin B12 deficiency. However, if you live a lifestyle where you don't eat animal products, and this goes on for a long time, and you're not addressing your vitamin B12, then you can develop vitamin B12 deficiency. So, what I want you to remember, in addition to hematopoiesis, I know this is a hematology lecture, but in addition to hematopoiesis, vitamin B12 is necessary for the myelination of nerves. So prolonged B12 deficiency can lead to nervous system problems. And the nervous disease we're talking about is subacute combined degeneration. And that's manifested by decreased deep tendon reflexes, decreased vibratory sense, particularly on the hands and the feet, a positive Babinski, paresthesias, and so forth. So subacute combined degeneration is another manifestation of vitamin B12 deficiency. Now you may have the anemia and not the SCD. Or you may have the SCD, the nervous symptoms, and no anemia. Or you may have both. You don't necessarily have to have one to have the other. But just know that prolonged vitamin B12 deficiency doesn't just lead to blood symptoms, it leads to nervous symptoms as well. Vitamin B12 deficiency, in addition to being seen classically in alcoholics, malnourished, vegans, it can also be seen in patients who have bariatric surgery, people who have Crohn's disease, and patients with atrophic gastritis, which is an autoimmune disease. So why is it seen in people with bariatric surgery? Well, the way we cut out part of their stomach, it cuts out the part that secretes intrinsic factor. And intrinsic factor is necessary for absorbing vitamin B12. So that can be a problem, particularly if they have the Roux-en-Y bypass surgery. With Crohn's disease can affect the whole GI tract. Crohn's disease has an affinity for the ileum. So if there's ileal Crohn's disease, then you can have problems with vitamin B12 absorption, because vitamin B12 is absorbed primarily in the ileum. And with atrophic gastritis, it damages the stomach, and so you're going to get a decrease in intrinsic factor, and that can cause a B12 deficiency too. So bariatric surgery, Crohn's disease, atrophic gastritis, any of those three things in the patient's medical history, that's a risk for vitamin B12 deficiency. How about folate deficiency? So this can be seen in alcoholics and the malnourished as well. However, folate deficiency can also happen in the reverse of vegans, people who do not eat vegetables. Folate is found in fresh vegetables. So I guess not only eat vegetables, but who don't eat fresh vegetables. Patients who primarily get their vegetables out of a can. So a healthy person only stores about 3 months of folate. So deficiency of folate is common. Not common as in a lot of people have it, but it's much more common than vitamin B12 deficiency, because you only store about 2 to 3 months of folate, whereas you store about 3 years of vitamin B12. So if you go 6 months without vitamin B12, generally you're going to be okay. But if you go 6 months without folate, you can be in trouble. There are certain drugs that can increase the likelihood of folate deficiency due to metabolism, and those drugs are primarily phenytoin, which is used as an anti-epileptic, the sulfa drug, so trimethoprim sulfamethoxazole, if somebody's on a long-term course of that, thinking probably particularly HIV patients who are on it for prophylaxis. And then sulfasalazine, and so that would be a patient with Crohn's disease or ulcerative colitis. Sulfasalazine is a commonly used drug. So certain drugs can increase the likelihood of folate deficiency as well. And of course, any of those patients who are on those drugs are advised to take supplemental folate, but not everybody listens to that. Okay, so the question then is, when do we know, is it a vitamin B12 or a folate deficiency, and how do we investigate it? So here's a sample patient. 44-year-old patient with known history of alcoholism presents to the clinic complaining of fatigue and difficulty concentrating at work. He says he gets 8 to 10 hours of sleep per night, but never feels fully rested. He is not on any medications, and besides his alcoholism, he has no significant medical history. So he's got a CMP, which reveals a sodium of 141. Again, these are all milligrams per deciliter. 3.9 of potassium, chloride of 101, bicarb of 26, BUN of 21, creatinine of 1.2, glucose of 102, and his CBC reveals a hemoglobin of 9.3, which is low, hematocrit of 27.7, white blood count of 6.4, platelets of 249, and the MCV is 113. So what is the most likely diagnosis in this patient? The most likely diagnosis is folate deficiency, because in general folate deficiency is more common. But the fact that this guy doesn't have neurologic symptoms does not exclude vitamin B12 deficiency. Remember, patients with vitamin B12 deficiency can have the neurologic symptoms of subacute combined degeneration with no hematologic symptoms, no anemia, or they could have the anemia with no nervous symptoms, or they could have them both. So you can't use the absence of one to outrule B12 deficiency. So folate deficiency is more likely, but he may have B12 deficiency, one, because he's an alcoholic. So we need to get, and because he's got an elevated MCV. So we need to know if he's got a vitamin B12 deficiency. So the best next step is going to be to get vitamin B12 and folate levels, particularly those vitamin B12 levels. If we give this patient folate and we just send him off thinking, well, he doesn't have nervous symptoms, so he must not have vitamin B12 deficiency, then we've done this patient an injustice because he could have vitamin B12 deficiency. And if we just send him off with folate, then you could correct his complaining, his presenting complaint, his fatigue and difficulty concentrating at work to a certain extent, but his B12 deficiency will still be there, and ultimately he will develop subacute combined degeneration. So you got to get levels of B12 and folate. So let's say you did that, and you got vitamin B12 was normal and folate was low. Now you can replace folate, and generally you're going to do this orally. Let's say, though, that rather than getting, say the question stem doesn't tell you what's the best next step. It tells you what's the best, or what's the most likely diagnosis. And it includes in this question serum levels of methylmalonic acid and homocysteine are both elevated. What does that mean? That means a vitamin B12 deficiency. If a patient has a high MMA, then he's got B12 deficiency. Anytime a patient has vitamin B12 or folate deficiency, they're always going to have a high homocysteine. But a high MMA is specific for B12 deficiency, whereas patients with folate deficiency will have the high homocysteine with a normal MMA. And so in this patient, then, the next best step in management will be vitamin B12 replacement, and it will likely be parenteral vitamin B12 replacement. Okay, so how do we treat the macrocytic anemias? How do we treat B12 and folate deficiency? So for vitamin B12, we replace it parenterally every day for 2 weeks, and then orally every month for life. Now, if the patient has any kind of GI basis, that's a risk factor for vitamin B12 deficiency. So say they had bypass surgery or they've got Crohn's disease, then you have to treat them with parenteral therapy for life. So they're going to have to get a B12 injection every month for life. Did I say every week? I meant every month. Every month for life. So in their case, they're probably getting B12 in their diet, but they're not absorbing it. So you have to give it parenterally. Everybody else, though, they can get it orally after you replace their B12 after those 2 weeks. With folate, that's just replaced orally every day, and they should be advised to try to get folate into their diet somehow. So patients getting replacement should be kept inpatient for 2 weeks, and that goes for either. So up to 2 weeks, and that's generally if their deficiency is severe, but you should keep them inpatient for a while. And the reason is because as they're making more red blood cells, their potassium may drop. So you want to keep these patients on cardiac monitoring and get frequent electrolyte counts. And generally the hemoglobin on its own should correct by about 1 point per week. So if you see a gradual 2 points after those 2 weeks, then they're okay to let go. But remember that patients getting B12 replacement and or folate replacement are at risk for hypokalemia. And so they need to be on cardiac monitoring and getting electrolyte counts. And if their potassium drops, then remember to replace with potassium chloride 10 milliequivalents. IV would be fine. So Over 2 months, you should get a normal hemoglobin and hematocrit, so you should follow up with these patients in 2 months, get blood draws. They should have a normal hemoglobin and hematocrit. If they don't, then you should consider possibly that they have an iron deficiency as well. So maybe you should get iron levels and investigate a possible a second cause to their anemia. Remember, like I said back at the very beginning, you can have a macrocytic anemia and an iron deficiency anemia at the same time. Iron deficiency anemia is the most common cause of anemia, so it's certainly possible you can have both. So if you don't get a normal hemoglobin and normal hematocrit after 2 months of replacement therapy, then you should investigate for other possible causes. And remember that nerve damage from B12 deficiency, if they have it, generally that's permanent. But once you start replacing the B12, it should stop.